Hello everybody, welcome to our masterclass program today and our webinar. Karen, can you move us on? So today's webinar is on an introduction to sex and relationship training. This is a two-part program. So we've got a webinar today, and then there will be later in the new year an advanced, more practical training. Next slide. So just to go through some housekeeping, first of all, you will be asked to interact with the webinar today. We've got a couple of questions that we'd like you to ask. We'll tell you when to do that. We've also would love for you to evaluate the training at the end through the polls app. If you could tweet us about the webinar, we've got our Twitter handle there, which is not called Twitter anymore, it's called X. So that's GMNISDN. We'll pop our link to our training page in the chat, so you can have a look at what other trainings are on offer. And you can email Karen for any other details with regards to the webinar. Next slide. So we're very lucky to have three presenters, as well as myself, Fahin Akhtar, and Abby, who is our patient involvement lead from that works with us and with Stroke Association. Very lucky to have Dr. Tamsin Collins, who is a consultant in Rehab Medicine. Dr. Leonie Rose, who is a clinical psychologist. Unfortunately, she's not able to make it today. However, she will be there for the advanced training, and she has helped us put some of this content together. So really lucky to have her as well. And then Jo, a lovely specialist stroke nurse and ACP from Bury Community and Stroke. So just to give you a little bit of context and background, this was a project or something that's come through our patient and carer group. It was highlighted to us by one of our patients that this was something of an issue for them. And it was a conversation that they never had, and that will go through their experiences. And as a result of that, we went out to our community teams, community and our acute teams, and really just scoped out what was happening with regards to these kind of questions, and was any training needed. And what we found was that predominantly it was the responsibility of the nurse. It kind of always fell on the nurse to discuss sex and relationships, and we often found that in some areas it wasn't a designated role, so there was no specific individual that was down to have these conversations, so a bit of a gap in service provision. In some of the community rehab teams, we often found that although an initial assessment, it might have been mentioned, but the teams weren't resourced to really have any effective discussions later on. And really, the training need that we that came across was that there was need for a training session on guidance, on practical solutions, on understanding, and really to boost confidence around what the resources were and what the signposting was. So that was the background on what we found with regards to scoping, but I'm going to ask Abby to come in now and just talk through the next couple of slides on some of the patient, the patient comments with regards to this. Thank you.
Yeah, so this topic came up quite briefly within one of our patient and carer groups, and then we met again to follow up a bit more specifically with people about their experiences, both in the acute setting, the community setting, and just kind of around their feelings as a reaction to those experiences as well. So I've just pulled out a couple of the comments that were made. The first two just on the far side there on the left. So these were both from an acute setting. The first one is from a stroke patient, or the partner of a stroke patient. So this is, he was texting me from the hospital, what if it doesn't work anymore? What if we can't have sex again? In the end, I told him to go to the toilet and check. I was so worried he wouldn't focus on his hospital care until he knew. It was all okay, but no information was available to us and no one asked us about it. So for them, they just wanted a bit more acknowledgement about it in the acute stage. Whereas somebody else said actually that wasn't the right time for them. I needed time straight after my diagnosis. I was too worried about other things. So that was somebody with a neurological condition. The next two in the middle there, this is from a patient and their partner. So they both reflected on the same situation. And And the patient said, what was I doing? I didn't know. I went to my GP who gave me Viagra, but I didn't like it. I didn't know what else I could do, and it was so confusing. And the partner said I felt overly protective and cautious, and I was worried about the psychological impacts of the change in our relationship. So yeah, that's then about kind of the impact of their experiences. And again, they were just after a bit more information about things. And finally, these two comments are about the community setting. So I remember bringing it up during an appointment and the nurse ran away. Her manager came through to answer my questions, but she looked awkward too. I was asked about sex and relationships after my stroke. I prefer as a woman if it is another woman asking me. So obviously within that we have kind of different personalities and different preferences coming through, but just to kind of show a range of some of the experiences that people were sharing from the services that they've been through. The next step of our conversation was just about some of the recommendations that they gave from their experiences. So everybody felt, even when the conversations, they differed about when was the best time to have conversations, they all thought an acknowledgement of sex and relationships would be beneficial. They thought more information, guidance and resources would be beneficial. Different ways to deliver information. Again, we talked about those different preferences within the group. They all had different ways that they would have wanted that information, whether it was talking about it or written information or signposting to other places. So the recommendation there was just to have those different options, and generally just more knowledge amongst health professionals and more confidence around that conversation, particularly around that person who had experienced awkwardness when she had brought it up. Just have more confidence to have those conversations as well. So those are the recommendations that they gave, and we came on from then about kind of how we can support with those, and this webinar's kind of come from that.
Thank you, Abby. It was a really a multidisciplinary approach that we've had, to try and create this webinar. We've really had everyone involved, especially the patients have been really involved from the start. So what we'd like to do now is I'm going to launch an instant poll, and I would like you all to answer within the poll, and then like anything that you think is the most appropriate from anything that comes up in the word cloud. But if you do that and then close that question, we will come back and reflect on that question a little bit later on after you've had some of the content that's been delivered. So I will launch the poll now. Let me go back down. Here we go. So you should all get that question coming up. So if you are able to respond, we'll give you about 5 minutes to respond to that question. It should be on all your screens. And then we can go through the results a little bit later. That's good to know it's working. And once you've responded, if you want to just close yours down or like some of the other ones, we know that the larger the text, I think, on one of these is the ones that you can go back on and then like different responses, I think. Perfect. And we'll come back to that poll. I'll leave it open for a little bit longer. And then we'll come back to to view the results a bit later. If you move the question on for me, Karen. So I'm going to bring in Dr. Tamsin now to go through the rest of the presentation. I'd like to welcome her to present. Thank you.
Thanks, Faheen. So I think really our learning objectives for today grew out of the insights from the patient engagement and also from the staff engagement about what people really felt would be helpful to allow them to start these conversations. So we've sort of broken down into 4 areas here. So our aims really for today are to consider and understand why we should consider sex and relationships as part of neurorehabilitation. Why does it fall within our job roles to be discussing this? We aim to improve knowledge about how neurological conditions such as stroke, brain injury, MS and cerebral palsy can impact on sex and relationships. We're going to share a model for structuring the approach. Again, there's no one way of doing things. It's just something that people might find helpful to help organize their thoughts and again boost confidence in starting the conversations. And at the end of the presentation, we've got lots of links to relevant resources that can be shared with patients and a whole lot of information contained within those. So we'd encourage you to have a look through those resources. Next slide, please. So I think it's probably helpful just to start with this question: what is sex? What are we talking about here, and why are we talking about it within the context of neurorehabilitation? I think I quite like this statement from the Headway Sex and Sexuality After Brain Injury leaflet. Sex is a basic function of life that relies on physical, emotional, behavioural, cognitive and social skills. So put like that, it's not surprising in a sense that actually it's something relevant to us where we're working with people who've often had illness or injury affecting all of those areas. I think if we consider sex, it really is the sort of ultimate biopsychosocial event, really, and it kind of brings together anatomy, hormones, medications, medical conditions, physical limitations. It also is affected by past experiences and expectations. And our cultural and social conditioning impacts, and then our psychological and emotional responses and our feelings about self are all important. So I think the second part of this is also just highlighting that actually sex gives people a sense of comfort, pleasure, fulfillment, and often creates a sense of closeness with someone who we feel is special to us. So for all of these reasons, it's an important part of life for many people. So I think we need to kind of hold that thought in mind through our presentation. Next slide, please. So when it comes to talking about sex and relationships, often our instinctive response is, "Ooh, am I the right person to do this? Can I do this?" And I think hopefully today our aim is to kind of give you hopefully some facts and some tips and increase your confidence just to start that conversation. We're not really we're not saying you have to finish it. I think one of the really telling things from the patient feedback was that actually just an acknowledgement of this as an area is so important. So just starting the conversation, you've done something good. And I think it's worth considering with ourselves as health professionals what attitudes we bring to these discussions and these conversations, and just having an awareness of that. And I think just remembering that actually no two sex lives look the same. So there is no standard for sex, and I guess as health professionals, that means that we need to be aware of bringing too many assumptions about what normal is to our conversations, and that leads on to this need for us to challenge stereotypes. Next slide, please. So thinking about what influences us as health professionals, I think it's perhaps helpful to take a step back from our day-to-day roles and consider what what we're doing in a sense in our day-to-day roles, and how that is different from many people's normal lives. We spend our working lives often assessing patients who may be in quite vulnerable situations. They might have very few or sometimes no clothes on at all when we're assessing and examining them. So how do we, as health professionals, how do we normalize those interactions? Again, there are no rights and wrongs with this, but sometimes an awareness of how we deal with the closeness that physical examination necessitates between us as professionals and the patients, and that physical closeness. How do we normalize that? Sometimes that's about it translates into almost infantilizing our patients to help us deal with that situation. And again, thinking about the impact then of whether we then bring up conversations about sex with our patients. Is that then a barrier to doing that? If in our minds we're actually almost considering our patients as children to help the awkwardness otherwise of that interaction. Thinking about our own experience as patients as well, being cared for. How would we like to have been cared for by health professionals? What went well? What felt difficult? Was our vulnerability acknowledged when we were being treated? Next slide, please. So I think this is a tricky question, isn't it? When and where does the ill patient become a sexual being again? And we heard different opinions coming through from the patients about actually how soon they hoped that this question would be addressed and discussed. And for some people, that is quite early on, and perhaps when they're still in hospital. So again, challenging our thoughts of that when we're dealing with an ill person, that actually they aren't also still a sexual being. Thinking, I mean, looking at the profiling bed here, treating people in a hospital bed, how does that influence our concept of a patient's sexuality? And then thinking about our patients as they go home from hospital into the community, they may go back into a very different setting from that which they left, with the hospital bed downstairs in the sitting room, and the total transformation of what was their private bedroom space that they shared with their partner. So again, worth reflecting on how we might respond to that situation going home, and what therefore might be important to patients. Next slide, please. So I think it's important to consider the sort of wider aspects of disability and sex. I quite like this picture at the top right, because it encompasses a couple of things. I think first of all that disabled sign on toilets, which seems to immediately render that disabled person as sexless. They're no longer a lady or a gentleman. They're a disabled person. So I think those, again, thinking about cultural stereotypes is important, and that image is starting to challenge us, and I think in terms of disability sexuality, there's actually a whole fascinating lot of writing and online content about disability and sexuality, and to some extent it's able to step back from our usual kind of hang-ups and is in some ways sort of free from some of the kind of sexual and cultural norms in quite a liberating way. And I think that's reflected in some of the things that are written. I was just going to read a little bit from something that Michelle Tepper wrote in 2002. which appeared online. It was so Mitchell Tepper is founder and president of the Sexual Health Network, and he's American, and he at the time of writing this was writing regularly for New Mobility's sexuality column Love Bites. And he posed a question to disability forums. What do our partners find sexy about our disabilities? And he said that the question was an attempt to focus on sexy as a normal part of the disability experience in relationships. Anyone who gets involved with someone who has a disability becomes suspect and is assumed a devotee. This does an injustice to all parties. The person attracted to someone with a disability automatically gets labelled as having a fetish, and his or her motives are called into question. The partner with a disability is assumed unattractive, suggesting one must be imbalanced to be attracted to us. And the person who's actually sexually orientated to some aspect of a disability, whether it be a brace or a stump or a leg bag, is automatically assumed to be deviant in all aspects of his or her sexual relationships. Sexual relationships and sexual orientations are much more complex than this. He goes on to feed back on various comments that came through on that disability forum, and his conclusion is as follows: for those who have questioned how anyone can find them attractive with a disability, here is your answer. Partners do find us, including things about our disability, sexy. Disabled does not equal unattractive, and disability has the potential to bring out some admirable qualities. Sometimes we don't believe it when our own partner says we are still sexy, because we may feel so different from other people without disabilities, or from ourselves in the case of an acquired disability. I think it's affirming for everyone to hear partners' perspectives. Next slide, please. Thinking about the effect of stereotypes, it's not just in regards to disability that we might be forming subconscious stereotypes. These are also other aspects that came out in a quite old study now in 2004 of GPs and practice nurses in Sheffield. These groups thought certain groups would be less likely to want to talk about sexual health, and they included Black and ethnic minorities, sexual identity or practice other than heterosexual, and middle and older age. Now, I don't know how things would be different. One hopes they would be different, but I think I want to sort of particularly draw out the age stereotype, because certainly those of us working within stroke, many of our patients are actually older when they have their stroke. And I think remembering that many individuals enjoy a healthy sex life into older age is important, because I think culturally, again, a bit like the sexless label on the disabled toilet, I think there is a tendency culturally for us to think of old age as in some way asexual, and assuming that old people aren't having sex and aren't going to want to go back to having sex after an illness or disability. Importantly, in this study, it didn't reflect the experience of those professionals who'd actually discussed sexual health with patients. Next slide, please.
Thanks, Tamsin. So this is where we find out what you guys said about the barriers to discussing sex and relationships and intimacy with your patients. I don't know if you can share that screen, Fahim.
Yeah, I'm going to try.
Magic.
Can you see it?
You can see a screen, but we can't see the question. We can just see the evaluation.
Okay.
There we go.
No.
Oh, no. No.
No. Let me 1 second.
Okay, no worries.
Why does it not let me launch it again?
I don't know, but it looks like I can see it. I don't know how well I can share it.
This one here.
There we go. We've got it. So the biggest thing that we've got there, so is the patient, which is interesting, and I don't really know whether that means what you mean by that when you say the patient, whether you mean that the patient isn't willing to talk about it, or I don't really know. But beyond that, you can see it seems fairly evenly spread here that lack of knowledge seems to be the next most popular, and so hopefully this webinar will help with that. There's also knowledge and skills, knowledge of the options, knowledge of the topic, lack of training. So all of this, yeah, okay, fair enough, yeah, because the word patient we used a lot in the responses, fair enough. But all of these lack of knowledge things seem to be fairly common, and age does come up there as well. Lack of confidence, lack of time. So hopefully we'll be able to help you with all of that in this training. At the end, if you feel like some of your issues that you were thinking of that were on your mind while you were answering that responding to that poll, if you feel it hasn't been addressed, then please do ask some questions at the end, because we're hoping that you'll come away from this feeling a little bit more confident and a little bit more equipped to at least start the conversations with patients. Okay, go for the next slide if that's okay.
Thanks, Jo.
I can't see the slides now. That's just me. Is it just me that can't see the slides? Oh, yay. Thanks, Karen. A superstar. Okay, and this is pretty much what you said is reflected in what people have said when the RCN did a survey to look at the barriers for professionals discussing sexual problems with patients. They found exactly the same sort of thing. So they didn't have the knowledge, there's a lack of training, a lack of confidence, didn't know what to do next, finding time for it, having some dedicated time to do it, and feeling whether or not it was appropriate, which is something that came up in the answers that you gave, and then some religious or personal views, which potentially pertain to things like age and that kind of thing. So it looks like those things haven't changed very much in the 20 odd years since this poll was done, and that's hardly surprising, given that there isn't a great deal of training on this generally within our you know, our own professional training. Sorry if there's a lot of noise. I'm in a bit of a noisy office. I'm really sorry about that. Okay, can I have the next slide? So one of the things that people who've had a stroke or have a neurological condition say is that their sexual needs are overlooked, and really that until it becomes a problem in inverted commas with sexually inappropriate behaviours, that's when these sorts of things come to the fore, but not as a discussion then, more of as a problem. And in this study in 2017, 97% of participants believe that sexuality should be discussed during rehab, but only 36 reported talking about it. And that's a higher number than a study that was done in 2020 that is cited later on, where it says 90% of people after stroke specifically want to talk about sex, but only 10% of people feel like it was discussed. So we have some kind of a professional responsibility to be meeting our patients' needs, and they are saying that that's what they want to talk about, and yet we don't feel that we have the skills to do that. Could you move to the next slide, please? So I've looked at the RCP guidelines for stroke, and this hasn't, so this is a 2016 guideline and hasn't been changed in the new guideline, and I've listed it here, but I'm not going to read it straight out. If you could go to the next slide, please. Okay, so there's quite a little bit more here, and I've summarised it in the next slide, so you can find it. There are a few little bits and pieces, but if you move on, sorry, Karen, to scoot through these slides. So in brief, we should talk to people about sex after stroke, soon after discharge, and at 6 months and every year. So this is what the guidelines say. Note that that isn't what the patient said when, even within the small section of subsection of patients that we have on our patient carer group, they want to be talked. They want this to be brought up potentially even in hospital. But the guidelines say talk to people about sex after stroke, soon after discharge, and at 6 months and every year. Reassure people that they can have sex and it's unlikely to cause another stroke. Assess for reasons, including medications review. It doesn't really give us any ideas of how we might assess for reasons, what tools we might use, so how helpful that guideline is. And then maybe prescribe Viagra, but not for the first 3 months. And then refer for psychosexual counselling if that isn't resolved. Now, when you look at that guideline, essentially it misses out lots of, it's talk to people, and then really that it's very medicalised. So the medicines review, prescribing Viagra, and then refer for psychosexual counselling, and really that ignores all of the bits in between that we can do as healthcare professionals. But that's the latest guideline, and there was nothing new from 2016 there. So that's our guidance. I looked at other neurological conditions. So in the Parkinson's disease NICE guidelines, they talk about hypersexuality as an impulse control disorder, which goes back to what that quote earlier was saying about how we only really look at it as a when it becomes a problem in inverted commas, rather than as a normal part of what we assess as an MDT. In the NICE guidance in 2022, they talked about sexual function in terms of bladder and bowel symptoms, but it should be assessed as part of a comprehensive review. Traumatic brain injury isn't mentioned in the guidance, in the NICE head injury guidance, or the TBI guidance. And in cerebral palsy in adults, the NICE guidance in 2019, it's not mentioned at all either. So there's very little for us to go on as stroke and neurological neuro rehab teams in terms of what we ought to be doing in terms of the guidance. So it's hardly surprising that as professionals we feel a little bit out at sea with this. And when you look at the general population, so people who haven't had a stroke, about 40 to 45% of women and 20 to 30% of men report some aspect of sexual dysfunction anyway. So this is it going on in the population anyway. And then when we talk to people who've had a stroke, between half and 3/4 of those people suffer a decline in sexual function, but we don't really know because we don't really ask. So we don't really know how accurate that is. But then this is a study I was talking about that in 2020, they found that less than 10% of patients receive any advice in spite of 90% of people hoping for advice relating to sexual dysfunction after stroke. So that's quite you know, that's a massive disconnect in what people hope for and what we deliver. Next slide, thank you. So in other disease areas, we have MS, people with MS reporting sexual difficulties, and as you can see, over 3/4 of people with relapsing remitting and with secondary progressive MS report sexual difficulties. It's a really big problem. Up to 80% of women in some studies after the people with MS, and in head injury, just the same. 62% of people reported reduced frequency of sexual intercourse. So we can see how much of a problem it is right across the range of conditions that we see. Next one, Karen, please.
Thanks, Jo. So this sort of brings us on to a bit of, I guess, structure about how we might think about the factors that impact on sex in our patients. So this model was developed in MS, but is applicable across neurorehabilitation, and it's not really intended to be a hierarchy of importance or indeed an order in which you should tackle things. It's really just kind of helps to conceptualize the different aspects. So it's broken down into primary sexual dysfunction, which is the neurological changes which are directly impairing the sexual response or feeling. So those are the damage directly from the brain injury or stroke or MS that are affecting sexual pathways. Secondary sexual dysfunction are those disease-related changes which might be indirectly affecting a sexual response. So things like pain, fatigue, continence problems, all might have an impact, but they're indirect effects. And then the tertiary sexual dysfunction are considering the psychological and cultural issues which can impact. So that model's just quite helpful to keep all of those things in mind, but as I say, is definitely not a hierarchy or an order to be assessing things, because patients bring their problems to us, so we need to listen in the way that they bring things to us. So considering primary sexual dysfunction, these are some of the ways in which neurological injury can affect sex. So at the top here, we've got reduced or absent libido, and thinking about brain lesions from stroke or brain injury, perhaps frontal lesion that might affect behavior and effect on relationships. So that brain lesion itself is leading to a reduced or absent libido. The effect on the regions like the hypothalamus, which produce hormones which affect sex drive, and we've got hypersexuality here, which is something which perhaps as professionals we perhaps fear encountering, and as Jo highlighted, is perhaps the first time where we even consider sex, when it presents as a problem, and hypersexuality often is viewed as a problem. But actually, it's the minority of cases that occurs in. And so, thinking about stroke, the vast majority of sexual problems associated with stroke are to do with loss of or reduction in libido, to erectile dysfunction, problems with orgasm, and general reduction in sexual activity, as opposed to increased hypersexuality. So I think it's worth mentioning and important to do so, but also not to become totally focused on that as a factor. Altered genital sensation, so that might be neuropathic related pain and altered sensation, injuries to the parietal lobe affecting sensation. There's impact on frequency, intensity of orgasm, erectile dysfunction, which we'll explore further, ejaculatory dysfunction, and reduced vaginal lubrication. So those are all examples of primary sexual dysfunction. Next slide, please. In terms of the assessment of erectile dysfunction, it's worth highlighting that erectile dysfunction may not be all due to the neurological injury. There are a number of different health conditions which can impact on erectile function, and it can be the first presenting feature of cardiovascular disease, and can appear perhaps 2 to 3 years before the onset of angina, for example. So it's worth, whether it's within your professional capabilities and usual practice, to screen for other conditions like diabetes or cardiovascular risk factors, prostate disease, hypothyroidism, depression, or whether it's about signposting to other colleagues or GP to say, actually, this patient has expressed concerns about erectile dysfunction. Could you have a look into whether there's any other contributing causes? It's worth thinking about the impact of lifestyle on erectile function. And this is something that we're quite used to talking to our patients about, and it actually can be helpful to emphasize just how beneficial potentially stopping smoking, for example, might be. So there's been some studies suggesting that a year after stopping smoking, 25% of men had an improvement in erectile quality. In terms of obesity has a significant impact on erectile function, and I've seen statistics that around 50% increase in erectile dysfunction in obese men, and alongside that, evidence that actually addressing weight loss can have a positive effect. So over a 2-year period, a third of men randomized to weight loss programs showed resolution of erectile dysfunction. So I think it's a hopeful message. These are things that you can do which actually might help with this. As part of looking at cardiovascular risk factors, obviously monitoring BP, which blood pressure, and checking bloods, which again is something that we can ask our GP colleagues to do, and checking testosterone levels. That needs to be a morning testosterone level to be helpful. Next slide, please. So in terms of what's going on here with these neurological injuries, I think perhaps we don't always perhaps think of the importance of the brain in terms of sex, but it really is the primary sex organ, and there's no one center in the brain which is responsible. So there are lots of parts of the brain which are involved, and that makes sense when you think about the different elements, I suppose, of sexual function, sexual response. So there's the sex drive or libido, which we've mentioned. There's perception of sexual stimuli and pleasure. There's movement, visual processing, cognition, and attention. So all of these affect different parts of the brain. And I guess perhaps helpful to think about some of the cortical elements of the frontal lobes, thinking about behavior and social skills. So that might manifest as inappropriate sexual behavior, but more likely perhaps is that it's actually manifesting as lack of motivation for sex, difficulties with starting sexual activity, alongside difficulties with attention and concentration. Thinking about the temporal lobes, again, important for sex drive, and damage in these areas can lead to an increased interest in sex or a decreased interest. But the temporal lobes are also important for reading emotions. So potential for misinterpreting behavior of a partner or others. So that can have an important impact. We've talked about hormonal aspects, hypothalamus, important for producing hormones that regulate sex drive, and then the amygdala, in terms of managing emotions, and can also affect orgasm sensations or sexual feelings. So that's just some of the ways in which the brain is involved. Next slide, please. Thinking about the pathways for erectile function in particular, I guess what's happening really is this neurovascular cascade event, which leads to the smooth muscle relaxation in the corpus cavernosa of the penis, and that's triggered by sexual stimulation, which then leads to increased parasympathetic activity in the sacral pelvic region, and that leads to release of neurotransmitters, smooth muscle relaxation, and then increased blood flow to the cavernosal arteries and arterioles. So that's really the pathway, and so the parasympathetic pathways, which are shown there at the bottom of the screen, are really of key importance. But the sympathetic pathways are also involved, as are the somatic pathways. So it will probably help if we talk a little bit about the different types of erections. If we go on to the next slide. So it's perhaps helpful to think about these different types of erection. So reflex erection, generated by direct genital stimulation, and you need an intact sacral spinal cord for that. So for those of our patients who've had perhaps high spinal cord injuries, cervical or upper thoracic, we might find that actually reflex erections are preserved, and enable a patient to engage in penetrative sex. Psychogenic erections are those which are produced by auditory, visual, olfactory, fantasy. So I guess not from direct genital stimulation, and they rely on motor pathways from the cerebral activation, and they involve the sympathetic nervous system that we saw on the previous slide, and the sacral autonomic centers. So in practice, people who've had sacral cord lesions may find that actually they have profound erectile dysfunction because neither the reflex nor the psychogenic erections are possible. I've put nocturnal erections there, because they can be helpful to ask patients about. I guess we don't fully know why they happen. That they happen during sleep, and they may be important for increasing oxygenation to some of the spongy tissues. It's certainly true that actually erections in themselves help to maintain erections. So in a sense, kind of viewing them as sort of housekeeping, keeping things healthy and functioning, so that actually when you need them, it's going to work. So a sort of a housekeeping erection, and typically preserved in psychogenic or hormonal causes of erectile dysfunction. Next slide, please. In terms of female sexual response, again, role of the hypothalamus and desire, arousal, sensory cortex being important for that, as well as more local sacral spinal reflexes, and orgasm mostly coming from clitoral stimulation, which is S2 innervation, but higher centers are also important. So we're back to the brain again, and then the spinal cord coordinating the physical elements, and the cerebral cortex perceiving pleasure. So again, highlighting how multiple parts of the neurological pathway are involved. Next slide, please. Next slide, please. Thank you. So I think we've popped this slide in, and we'll sort of come back a bit to medication, but I think it's probably worth highlighting at this point that medications themselves can be associated with sexual dysfunction, and there's a list there, and an awful lot of them starting with anti. So a sense that effectively they are dampening down, and it often results in a dampening down of sexual response and function as well. Antidepressants are particular culprits, can have an impact on libido, erectile dysfunction, vaginal dryness, and anorgasmia. SSRIs have seen statistics indicating that as many as 50 to 80% of users experience reduction in sexual desire, also associated with delayed ejaculation. It's worth saying that there are better alternatives, I guess, in terms of antidepressants to consider. So mirtazapine is associated with fewer sexual side effects and may be something to consider if patients need to be on antidepressants, but perhaps considering a switch may be helpful. Cardiac medications can be culprits. We've got thiazide diuretics, we've got beta blockers in there, spironolactone. So alternatives, in particular in terms of sort of blood pressure management, so ACE inhibitors, far fewer problems with sexual side effects than beta blockers. But again, with all of this, it's sort of having an awareness, and obviously important that patients don't suddenly stop all of these medications, but it might be that it's about signposting to conversations about whether there might be dose alterations that could be helpful. Maybe it's about the timing of taking some of their medications. Maybe it's about having a holiday from some medications. So I guess, again, just signposting back to prescribers to say, well, actually, sexual function is a problem here. Are there adjustments to medication that might help? There might not be, but it's a conversation that needs to be considered. Next slide, please.
Okay, that's me. Thanks, Tamsin. So looking now at secondary sexual dysfunction. So as it says here, how other things related to a neurological condition or stroke can have an impact. Next slide, Cam, please. Cool. So some common physical problems that we might get with a neurological condition. And this kind of goes back to where we talk about where does sex start, actually, really, when we're thinking about it. We're talking about intimacy as well, aren't we? And we're talking about how you know, sex doesn't just start in the bedroom. It starts before that. It starts with you know, acts of intimacy like kissing, like you know, like talking to each other, those kinds of things. So you know, there's quite a lot involved here. So obviously we've got the big ones like loss of movement and loss of sensation and spasticity, pain, fatigue. Also things like bladder and bowel dysfunction and how that's managed in intimate situations. But also things like dyspraxia and coordination problems can be quite a barrier. Some oral dyspraxia and how you manage that alongside things like kissing and oral sex and that kind of thing. Your visual field deficit, making things, and the dizziness that might be associated with cerebellar strokes, any kind of vestibular issues. So all of those are kind of things that might come along that we deal with all of the time as an MDT. And so if you could bring us on to the next slide, Karen, it is an MDT issue. So when you're thinking about how a person's deficits after their stroke or with their neurological condition, how that might impact their day-to-day life, can you extend your thinking about how that might impact them and think about how it might impact on sexual function as well? Therefore, you know, when you're talking about or when you start to kind of venture into talking and asking people about their sexual function, how can you apply your knowledge that you already have related to all the things you've already assessed, if they do come to you or if you do start a conversation and they are saying that there are difficulties, just going back to where this might have originally come from and the assessments that you've already made might inform your response. And thinking about that and then thinking, is there anything extra that you might want to assess related to the you know, for example, if you have somebody with an apraxia and then they come to you with a an issue with sex and intimacy, thinking about how might that impact and what kind of problem might it be that might relate to that is a really a good way of basing your response in the knowledge that you already have. Go on, Karen, the next one, thanks. There are some special instances that I wanted to bring up just because they rarely come, and we'll go much more into this in our masterclass, but it's more around, these might come up. So did the stroke happen during sex? That's not something that is unusual for us to hear about. Just to really reassure people that it's rarely implicated in any kind of stroke. There's no direct causal link with dissection. Strangulation as a sexual practice seems to be more prevalent these days, and that's something to bear in mind. And again, not something that I think is going to come up very often, but it's definitely worth paying attention to. And then birth control. So for women who have been on the pill, that's something that probably younger women particularly, and in relationships or not, you know, worrying about pregnancy and the limitations on being able to take the combined pill is something that probably needs to be brought up so that we can talk about that kind of thing if it's relevant. At least it's worth bearing in mind that that might be an issue in your discussions with people. Karen, would you mind moving on? Thank you. And Tamsin's already covered this, but there are various comorbidities related to cardiovascular disease that are common in people, particularly with stroke, that we might be thinking about. So it's worth bearing in mind, giving a nod to those other vascular risk factors that are very common in impacting sexual function. And as Tamsin said, trying to signpost people if that's the issue. But you know, quick things that people can do, well, not quick, but things that people can do, such as stopping smoking, that are within their control, controlling their diabetes better, and losing some weight. All of those they're not easy things, but they're potentially straightforward things that can have an impact, and with support. Okay, next slide, Karen, please.
So these next slides are actually have been put together by our colleague Leona, who sadly is unable to join us today. So Joe and I are going to do our best to talk to these slides, but really just thinking about the tertiary impacts. So psychological distress associated with a neurological condition, and I guess as this slide highlights, also psychological distress associated with the sexual dysfunction after a neurological event. Next slide, please. So Leonie's pulled out this definition from the WHO, which I think again nicely complements what we spoke about earlier in terms of the extent and role of sex in people's lives. So sexuality is an integral part of people's existence and is related to quality of life. Sorry, my computer has decided to lock me out. Let me get back in.
I mean, I think, go on, carry on then. I was just going to take over. You carry on.
So again, you can see that the definition there, central aspect of being human throughout our life that encompasses sex, gender, identities and roles, sexual orientation, eroticism, pleasure, intimacy and reproduction. Sexuality is experienced in thoughts, fantasies, desires, beliefs, attitudes, values, behaviors, practices, roles and relationships. So yeah, it kind of nicely brings us back to so in terms of this study from 2020, looking at intimate relationships, that it sort of identified 7 sort of broad themes where intimate relationships might be challenged after a neurological injury. So there's the coping with the direct effects of the injury itself. So as we've spoken about, impact on communication, physical aspects, the behavioural and cognitive difficulties of the direct effects of the injury, and then perhaps the partner and the survivor having perhaps different perspectives on the situation, whether that's about whether sex is desirable at the moment or not, whether it's going to be possible or not, and what the hopes for the future are. So that kind of being on a different page, in a sense, may be in itself a barrier to communication as well between partners. So that's comes through in this sort of strained communication. So there might be the practical aspects of communication. Maybe the stroke survivor has aphasia following stroke, so actually it's very difficult to communicate on a day-to-day basis, let alone in terms of from sex and intimacy perspective, and to what extent they're able to communicate emotional needs as a couple. There may be other factors coming in externally, so worries about finances, about future health problems, and then there's the adjusting to different roles within the relationship. Perhaps overnight, someone has gone from being a wife to being a caregiver, and the impact of that, the shift in responsibilities, perhaps. Perhaps a partner's had to give up work in order to be involved in caregiving, and that sense of identity for the partner, then the impact of actually how they used to be together, what activities they used to enjoy together, perhaps meeting up with friends is no longer possible. So all of these can have an impact on intimacy. Joe, just while we're talking, it might be worth just muting, just because we're picking up some of your background noise.
Sorry.
Thanks. That's all right. Then there's amplification of existing relationship difficulties. So it might be things that were actually quite difficult even before, but they had ways of managing that, and perhaps those are less possible now. There may have been amplification of some aspects of personality or behaviours. And then there's the wider support aspect from other family members or friends. So perhaps lack of understanding, and perhaps feeling increasingly isolated from other social networks, all of which have an impact. Next slide, please. So in terms of thinking about impacts on intimacy, we've started to touch on these already, and with what we spoke about with the primary and secondary factors. As Joe said, it's not all about intercourse in the bedroom. It's actually, intimacy involves a whole lot of other social and behavioural interactions, which can be impacted. And so we've kind of considered some of these barriers already. In terms of roles, again, the aspects around overprotection, there may be a lot of anxiety, not just from the patient but also from the partner about resuming sexual activity. And so it can be really important to explicitly address this and reassure that that there's no evidence that anyone is any more likely to have a stroke during sex than at any other time. And in terms of aneurysms, again, sometimes it can be important to link back in with the neurosurgical team, but really to be very reassuring that if an aneurysm has been fully treated, that again, the risk of recurrence should be very low indeed during stroke. But it can be a real factor for people who have actually had their subarachnoid hemorrhage during sex. And but actually addressing that head on can be really helpful for people to voice their kind of unspoken fears about this. Managing difficult feelings, just being able to give a space for people to be able to share some of those feelings, not having to have a fix-it approach, but just actually being able to hear and reflect back and allow partners and to be able to hear each other's perspectives, and an acknowledgement of fear, which can accompany thoughts of the future. Next slide, please. So again, just emphasising this biopsychosocial approach, really, that is a thread throughout our presentation today, really, and these interlocking aspects that impact on sexuality. Next slide, please. It's worth highlighting depression as something that is very that clearly is more common after neurological injury, and something that we see on a regular basis in our work, and thinking about depression and low mood as a cause for reduced libido and sexual desire. So and thinking about how people following neurological illness may feel about themselves. So these are some of the feelings that people reported following a neurological diagnosis: feeling like a burden, dread for the future, feeling broken, feelings of being unworthy, feeling ugly or unattractive due to physical changes. So those thoughts and feelings, it's not hard to see how they then impact on engagement with relationships and resuming sexual intimacy. Next slide, please. So we've put this case study in just to as an example, I suppose, of how one might start to conceptualize some of the different factors impacting. So this is a gentleman who was 54 when he was involved in a cycling accident, had a traumatic brain injury, and was admitted overnight to hospital. And the scan showed a shallow acute subdural hemorrhage, fracture to his right maxillary antrum. So he's only in hospital overnight, so very little chance really to discuss what has happened. He has follow-up with our community neuro discharge team, which is OT led and able to see people at home. In the following year, he is linked into our community Neurorehab team and is seeing the occupational therapists and psychologists through our service. And he's referred to me with erectile dysfunction and loss of libido. So some of the other background: he lives with a long-term partner. He's really struggling with fatigue and impaired attention. He has low mood, and partner is reporting concerns about angry outbursts. There are others in the house, so their son lives with them. They have grandchildren coming in and out of the house. That previously wasn't an issue, but now he's struggling to cope with the noise associated with that, and is having input from the team to support with a phased return to work. So next slide, please. So if we're thinking about this way of, I guess, kind of drawing together different factors, thinking about what might be the primary, secondary and tertiary factors involved here. Next slide, please. These are just some of the things that we might want to consider. So thinking about possibility of hormonal changes, checking pituitary function, and those tests are normal. He's highlighted, and the neurocognitive testing is highlighting problems with attention and concentration, and thinking about the impact that might be having on sexual function. thinking about fatigue in terms of the secondary indirect aspects, and there may be others to draw out of from that as well. And then some of the psychological impacts. We've heard a bit about low mood, these angry outbursts. How is that impacting on the relationship, and what are his partner's expectations? How have their roles shifted since this injury? So those are some of the ways we might kind of use this framework, I suppose, to draw together our thinking and approach. Next slide, please. So this leads us on to how we might start to approach managing some of these things that we've identified, and we're going to introduce a model which is the explicit model as a way that people might find helpful to conceptualize that. We're also going to speak briefly about some of the medication aspects of treatment, consider some of the physical aids for arousal and erection, and then in this webinar we're not particularly focusing on psychosexual aspects and counselling, but it's something that we may well pick up later, but important to be aware of onward referral options to specialist psychosexual counselling where that's needed. Next slide, please. So this model is it's an acronym, so it spells out permission, limited information, specific suggestions, and intensive therapy. So it's a model that was initially developed as the Plicit model in '76, and then had additions to it to make it the explicit model. And the addition really was the realization that really we need to be giving permission at each of these levels. It's not just that we seek permission to discuss once. It's giving permission to talk really at each of these levels. So next slide, please. So in terms of permission, I thought it might be helpful just to put some of the questions that we have found helpful within our service to draw out whether this is an area that patients want to discuss. And we've included some of these in our initial assessment so that for anyone coming through our service, they are explicitly asked or given an opportunity.
I'm just logged out, I've not.
Oh, sorry, that was.
I'm just not there, that's why. I'll go back on. Where's my
Somebody's just come off mute. Could... Thank you. Yeah. So these are just examples. So people with a neurological condition may experience difficulties with sex or with relationships. Is this an issue for you? Would you like to discuss this? So an opening gambit. Another approach, many of our service users have some relationship or sexual concerns. It's not particularly my area of expertise, but I appreciate its importance. So immediately you're not, I guess, putting yourself out of a comfort zone. You're highlighting, I'm not an expert in this area, but I do appreciate its importance. So you're validating that patient's experience. If you would like, I can ask my colleague to speak with you. So that perhaps might be a different approach from the scenario we heard about earlier where the nurse ran out of the room. So it's being able to actually acknowledge and say, yes, this is important. I may not have all the answers for you today, and that's okay. We can start this conversation, and I can elicit help as needed. This next one is perhaps thinking about some of our younger service users, perhaps who are transitioning into adulthood. We see young adults with cerebral palsy, for example, and it can be quite helpful to be a bit more direct. I think we sort of hedge around questions a bit, but actually young people are much more, they're much more direct often and respond to more direct questioning. So, are your friends in relationships? Have you got a partner? Are you having sex? come out with the question, are you having safe sex? This might, you know, they might not have felt that the discussions about sexual health were relevant to them. They may not have felt that they were I guess directing this information, you know, how do I fit with this? I'm not like other people. So actually, you know, basic sex education, you know, to what extent have they actually had that and engaged with it and felt that it's relevant to them? So these are yeah, being direct can be helpful. And just important to think that, you know, by overcoming our embarrassment, we give patients permission not to be embarrassed. So yeah, just some thoughts on permission. Next slide, please. Jo, I'll hand over to you.
I do apologise for the background noise. This is usually a very quiet office. So limited information is really around what can we tell people about the ways that illness can impact them. So we know all of this already. You know, thinking about how we already talk to people about the impact of the things that have happened as a result of the stroke or neurological condition. Thinking about things like medications, as we've touched on, as we've already talked about, dispelling any myths around how having a stroke can bring, having sex can bring on a stroke. So those kinds of things are very important. And directing people to other sources of information. The thing that I think is important is that we often have things that we don't know in other areas. So it might be to do with, I don't know, any aspect of rehabilitation. There's often something that a patient will ask us that we don't know, and we're more than happy at that point to say, I'm really sorry, I don't know the answer to that question, I'm going to go away and find out. And that's no different with this. There's no difference here. If you don't know the answer to a question, there's absolutely nothing wrong with just saying, I'm afraid I don't know the answer to that question, but I can go away and find out. And you know, we're quite happy to do that in other situations. So remembering that nobody expects you to have every single answer to every single question. So this limited information within the scope of what you already know is, you know, you don't need to stretch yourself outside of that and know all of the answers. Next slide, Karen, please. So what do you already know? So if it's fatigue, how do you manage fatigue? What can you do? Is it different from intimacy than for any other activity? You know, if it is loss of sensation, what do you know already about loss of sensation? Can the same principles apply? You know, regardless of whether or not it's related to sexual function or not. All of these things that we already have knowledge of, can we apply our knowledge that we already have and put it into that sort of intimate situation in order to advise? Because quite often we do have that information there already, and suddenly it becomes a blind spot when we're talking about it in terms of intimacy and sex. And actually we probably have some of this knowledge already. Next slide, Karen. So there's some specific suggestions that I can come up with, which sometimes are quite helpful to kind of get you thinking about how are the different ways that you might be able to think about things that we already use, adjuncts to rehab that we already use, things that we might already suggest for different kinds of problems. How could we apply those? So it's a kind of, in a lot of ways, it's a problem-solving approach. This is how we do rehab. Right, this is what we do as rehab professionals, as an MDT. So what have we got in our kind of toolkit that could help with this? So though we had a look at an electric bed as being a barrier to providing to talking about sex, actually an electric bed is one of the easiest ways to assist with positioning for sex and increasing abilities. So I've lifted this quote directly, actually, that I lifted this quote directly from a patient advice leaflet that was written by other service users, where you can apply to charities for an electric double bed if you want to, and you can get electric beds for these kinds of things through social services and OTs, which we know that this is kind of information that was given to patients by patients as to how they can manage things like positioning, which is one of the most difficult things if you have a hemiplegic limb or a, you know, spasticity or these kinds of things. So thinking about using what equipment is already there, handling belts. So we don't use them as often anymore, but actually they're really useful to enable people to help with holding, moving, positioning, those kinds of things. So what have we got at our fingertips already? Karen, next one, please. Things like slide sheets. How can we use those? How can we show people how to use them? Not specifically, I'm not saying that you want to specifically use them, but if people know how to use them for moving and handling, then, you know, it opens a world of possibilities at how you can use them in other situations. Wedges and cushions, those kinds of things. And then thinking about people with vestibular problems, seating positions are really helpful. We could go back to that slide from the, I absolutely love that slide, Tamsin, of the wheelchair user toilet and the different positions. Like, you know, you have to be a bit imaginative, and people don't need you to tell them. This is the other thing, that people can use their imaginations if they have permission to do so. And I think what you're kind of, what I'm trying to say here is that by engaging your kind of problem solving creative brain, you can often give people permission to use their own problem solving creative brain to come up with solutions for this. Combating fatigue is often a thing. So usually, not usually, but sometimes having sex in the evening is a normal thing, but actually perhaps earlier in the day, planning it around naps or morning sex, those kinds of things. And people with an apraxia or tremor, using like adjuncts like vibrators and stuff like that can really help. So these are things that this is the specific suggestion part of Plicit. So I'm not saying that you necessarily want to go into this every time, but these are some of the things that you can think about. And hopefully by looking at this, you can see how you already have knowledge of you know, how you might be able to combat some of these in other circumstances. So using that knowledge to transfer into these specific suggestions around sex is sometimes, you know, you can sometimes do that. Next slide, please. The specific issue that people are very concerned about is bladder and bowel dysfunction, because obviously thinking about bladder and bowel dysfunction in terms of loss of control and cleanliness and hygiene, all of that kind of stuff, and embarrassment, it's another added issue. People really struggle to get their heads around this, how they might be able to manage this. So there's some very practical elements. So emptying your bladder before sex, considering suppositories to empty the lower bowel prior to sex, adding a shower into the mix. So it's not just for personal hygiene, but if continence, particularly urinary continence, is a problem, getting into the shower, shower chairs, grab rails, those kinds of things. What we often find is people limiting their fluid intake if they're incontinent of urine. So really just sort of cautioning people not to do that, but actually just limiting it for a couple of hours before rather than overall fluid intake. Sex is completely possible with a catheter, so much more comfortable if you just bend the catheter back against the penis and a condom applied, that'll just keep it in position, or just tape the tube to the side of your leg, giving lots of slack, and just, you know, lots of towels, lots of continence sheets, lots of cloths and wipes, and a big sense of humour and a lot of love, I think is how bladder and bowel dysfunction can commonly be managed. I think that the bringing it up again as part of this Plicit model, bringing it up as a potential issue often just breaks down that barrier to talking about it in the first place, and allowing people to say, I'm really worried about this, how might I manage this? And then the knowledge that you already have, or as I say, you know, going back and saying, I don't really know, but here are some things that I've heard might help, can be very helpful but allowing people to talk about it, because people quite often struggle to talk about bladder and bowel dysfunction anyway, and then if you add sexual function into the mix, it makes into a very big kind of difficult, spiky issue. So being able to talk about it openly is something that is really very helpful. Next slide, please. Okay, so these are the only slides again, and this is about the ACT approach. I believe that a lot of people within the network here on the training have done some ACT training, so hopefully this is a refresher for those of you that don't. I'm not an expert in this, but I'll try my best to talk through the slides. So ACT, not ACT, but ACT is acceptance commitment therapy, which is around accepting the things that are outside of your control and then committing to action that improves and enriches your life. And as you can read, it's to maximize human potential for a rich, full and meaningful life. So it's around developing the skills to help you deal with more difficult thoughts and feelings, looking at what's within your control and how you might be able to change your thoughts and feelings to reduce their impact and influence over you. This is very values based. So this is around working out what your values are to guide, inspire and motivate yourself to take action. So the things that matter to you, the things that help you to live meaningfully and change your life. And it focuses your attention on what's important, allows you to kind of be fully present in whatever you are doing. That's the idea behind acceptance and commitment therapy when talking about distress. So within that, values is something that is it's very values driven. So values help us make compasses, help us make choices. They're like a compass that help us make choices based on the directions we want our lives to go. Values, there's lots of values-based exercises that you can find on the internet when you're looking at values. There's often lists of, 100 values and you pick the most meaningful ones. But if we connect with our values, we're able to move in a direction that's meaningful to us. So when we're talking about things like values, though it's very individual, we might be talking about things like health being a value, or honesty being a value, or success being a value, or there's lots of different values that you might want to talk that people can pick from. But if they can pick out the most important values for them, it means that they're able to move forward even when things are painful or difficult. So one of the difficulties in identifying values is they're not based around what other people expect of us, but what we think we should be doing. And that's very common. You kind of having a big list of shoulds. I should be able to, I should do this, or I should feel like that. But actually, what are our values when we drill down into them? And that's what ACT therapy is all about. Next slide, please. And when we talk about these, really, we're talking about, and this is where I'm getting quite out of what I know about. So, but I know that when we have a situation or a thought or an emotion, we have a couple of things that we do. So when we have this difficult emotion, we have a choice point. So what do we do? So we can either look to our helpers, which are our values, and what in our values can help us. So what do we focus on? What are our strengths in this situation? How can we support ourselves in this situation? And that means that we move towards a behaviour, towards a way of behaving that makes you more like the person you want to be. And then our hooks are the ones that are like where we are kind of old behaviours, the behaviours that don't help us, the opposite of help us really, and they undermine our efforts to change our behaviour. So that's where we move, where we have behaviour that moves away from or not like the person we want to be. So there might be an example of this might be we have, and this can be applied to both partners and to the person who has had a stroke or neurological injury. But for example, somebody who's presenting with not really feeling in the mood. So when you look at your kind of hook, it could be something like, you know, well, I'm obviously not attractive anymore. I'm, you know, no longer, you know, they don't want me anymore. And that moves you into a way of behaving, which is not like the person you want to be. So it's much more like, you know, into a kind of conflict situation. Whereas if you look to your values, which might be around thinking the best of people, or around those kinds of things, then your action might be much more of a helper in terms of, well, my partner's obviously tired after a long day. It's nothing to do with me, it's much more to do with them. And that allows you to move towards behaving effectively like the person you want to be. And then it's identifying these choice points that therapy helps us with. Next slide, please.
Thanks, Jo. And so, coming back to medication, I guess some of the secondary factors that Jo's talked through might be treatment of those might include medication. So, for example, pain, if that's neuropathic pain, causing unpleasant genital sensations, for example, it might be that actually we might want to consider medication to help with that. We've spoken about reviewing medication as a potential cause of sexual dysfunction. And then we're moving on to thinking about specific treatment. And in this regard, we're largely focusing on erectile dysfunction. Next slide, please. So the PDE5 inhibitors, which was introduced in the 1990s, really have transformed this arena. When we that there are different types of these medications. The most commonly ones that we use are sildenafil, which is also known as Viagra, and tadalafil, which is Cialis. So just a few bits of information about these drugs. They're actually quite effective. So that's an overall effectiveness. So not specific for people with neurological conditions, but effective in around 70 to 80%. They have the advantage that they're not invasive, they're tablets. They're generally well tolerated. They are associated with side effects, which are dose related and might limit their use. And the typical side effects that we warn patients about are headache, nasal congestion, facial flushing, blurred vision, indigestion, and there is a low but real risk of priapism, which is more of a factor when we come on to the other treatments that I'll mention. So I mean the medication itself is acting to dilate blood vessels, so it's increasing the blood flow to the penis. That's how it works. It's helping, it enhances the erection and makes it last longer. Importantly, when you're counselling patients on using the medication, you still need to have sensation and normal arousal for them to work. And it's possible to enhance that sensation, for example, using something like a vibrator, and that can help the effectiveness. I think in terms of the timing of the medication, certainly with Viagra, it's important not to take it with meals, because that affects the absorption. So having it on ideally on an empty stomach, and it's taken sort of 30 minutes to an hour before sexual activity. Tadalafil stays in the system longer and can get around the issue of spontaneity. So it's possible to have a daily dosing of tadalafil, which then allows more spontaneous sexual activity. There are drug interactions to be aware of, and it must not be used with nitrates, nicorandil, or alpha blockers, and that's because of the risk of blood pressure drop. So, and these medications are also avoided if the patient has low blood pressure. So that's defined as a systolic blood pressure of less than 90. We've spoken about the guidelines saying that to avoid PDE5 inhibitors in the first 3 months after stroke, and the advice with myocardial infarction is not to use them within 6 weeks of a myocardial infarction, and also to avoid in any case of unstable angina. Next slide, please. So it's worth it, and actually probably, sorry, could you go back to the previous slide? Because one thing that's I haven't put on this slide, which is perhaps important to mention, is that in terms of assessing effectiveness, it's really important to use these medications on multiple occasions before deciding if they're going to be effective or not. So the advice is to start at a lower dose and to try that lower dose with sufficient sexual arousal on at least 4 to 6 occasions, potentially more, before, and then if it's not effective at that lower dose, then increase the dose and again try it on multiple occasions at that slightly higher dose. And only when it's been tried at the highest possible dose with the presence of sufficient arousal on an empty stomach to conclude it's not going to help. So I think it's not enough just to try these medications once and say, oh no, it didn't help. It might be that side effects stop the use, and that's something slightly different. But yes, so it takes some time to work through these. And in terms of effectiveness, it isn't that one's better than the other in terms of the different types of PDE5 inhibitors. There can be some individual differences in terms of how people respond, so it's worth working through those. Typically, GPs will be happy to prescribe Viagra, the sildenafil and tadalafil. I guess beyond that, it might be that actually it's through a more specialist urology clinic and a referral through to that to try options beyond that, both oral and injection, as I'm coming on to. So next slide, please. So in terms of other options, if oral medication is not going to be helpful, then for some people, penile injections can be very, but they are very, very effective. And they actually produce a harder erection sometimes than is achievable with the oral medication. They don't need intact sensation to work. The downsides, I guess, around having to self-administer can be painful. Again, the need to plan, lack of spontaneity, and the risk of priapism. So the advice is that if erection is lasting longer than 4 hours, that the need to go to A&E for that to be treated. And I guess that what can be a barrier for some patients is this sort of medicalization of sex. But if that isn't, and again, it's sort of where we bring our own attitudes in. It's being aware that actually people may feel very differently about this, and if it's enabling erection and penetrative sex that otherwise wasn't possible, it can be life-changing for people. So important to be aware of these options. And again, this isn't something that in our roles we would be prescribing, but we would be signposting on to specialist urology clinics to assess and prescribe these. Next slide, please. And then thinking about other aids, so vacuum devices, again, the principle that they are creating a vacuum around the penis that then draws blood into the penis. What can be off-putting for some people is that it's therefore a cold erection because it's not as a result of the blood flow. So yes, it's a cold erection, which can be off-putting for some people, but again, it can be something that avoids any medication, risk of interactions, and then we spoke about the role of vibrators in terms of boosting sensation, and I've put the website for Spokes because that has all sorts of equipment that could be helpful for sex, and including things like positioning equipment like Joe's touched on as well. So it's worth having a look at that site. Next slide, please. So this leads us on into sources of information that we might want to signpost our patients to. These are all clickable links to websites or leaflets, and again, which sort of updated from time to time. These are all currently in existence and worth having a look into. So you can see that there's a wealth of information out there for the sort of individual for different neurological conditions. MS Trust, MS Society also has information. MS International Federation there. We've got Stroke Association and Different Strokes, which have got lots on their website. I do like the leaflet Sex and Sexuality After Brain Injury, which is a headway leaflet written by a neuropsychologist, and that really goes into some depth in terms of the different aspects of brain injury in particular and how that can impact, but certainly highly relevant for stroke as well. We've got spinal injuries there, and also cerebral palsy, and worth having a look at that site, which is the Adult Cerebral Palsy Movement site. Next slide, please. I found some of these resources quite helpful to signpost people towards, which is more about general impacts of disability and sex. The Outsiders Trust is an organisation run by and for people with disability, and it provides a sort of curated dating site, really, and opportunities for social interaction beyond not just romantic, but also allowing people to meet others, because often when I meet young people with cerebral palsy, one of the big difficulties is that they're not getting a chance to really meet other people and develop relationships that could then lead on to romantic and sexual relationships. So the Outsiders Trust is worth pointing people towards, and these are some other aspects. The Sexual Health and Disability Alliance, they've got lots of useful information on there. Enhance the UK, again, involved in training of professionals, but again, they've got information on their site. And then the Relationship Counselling Service, again, it may be important just to allow couples that space and opportunity to be able to seek specific relationship counselling. And next slide. These, thinking about support and training for health professionals, I suppose being aware that there's a College of Sexual and Relationship Therapists, which is the professional body for psychosexual and relationship therapists. They may be organisations that we want to signpost patients onto, and that's going to the intensive therapy part of Explicit. So it might be that we're not providing, and very likely that we're not providing the intensive therapy, but actually having provided all of the other elements of the Explicit or introduce those, it might be that actually we want to refer on. And in our in the workshop and things that we sort of follow on program that we want to deliver later in the year, will have more of an opportunity to explore perhaps some of the psychosexual aspects that maybe within our work we are able to usefully do. And interestingly, the Institute for Psychosexual Medicine trains doctors and health professionals. So it's not just for doctors, it's also AHPs and nurses who see patients with psychosexual dysfunction presenting within their normal practice. And I've attended seminars over a number of years, and my seminar has actually been led by a consultant in now retired in rehabilitation medicine. So it very much does sit within rehabilitation as well. So thinking the opportunity to think about how in our normal consultations, what are the skills that we can use to actually allow patients to reflect on what's happening, and actually in that scenario I've often found unknowing being as helpful as knowing. It's really helpful to actually take the doctor hat off in that situation and just be as curious and unknowing as our patients, and that takes you to some surprising and often very helpful areas. So yeah, that's just a kind of a flag for that. Next slide, please. So in conclusion then, we hope that we've convinced you that sex and relationships are important, and they're important for us as neurorehabilitation professionals. We owe it to our patients to ask, and sometimes just asking is enough. We hope that with the use of models like Explicit, that gives you a little bit of a framework, and our assessment framework with primary, secondary, tertiary, to be able to organise our thoughts a little bit about that and give us the confidence to be able to offer, again, most importantly, our ear to our patients, but be able to know that within our usual practice, actually, we've already got a lot of knowledge which we can apply and share. As I touched on just now, being prepared not to know often can be the most powerful thing. So don't be frightened of that. And there are lots of resources out there. We've shared some of them in the resource section. There are lots more, but they're hopefully helpful starters. So many thanks for attending.
Well, thank you, Dr. Collins, and thank you, Joe. It's been really informative. So before I think we go into the Q&A, I'm going to put up a poll, just start evaluating the actual webinar, and just a couple of questions helping us to formalize the training, that's the advanced training, and then we can go into a Q&A. So if you've got any questions, if you pop them in the chat, if you'd like to raise your hand, I can pop on your computer, your camera and your mic, and you can actually ask or interact with the presenters if you'd like. But if I can just launch the poll, which again hopefully will help us sort of evaluate the session, and then if you can answer the 4 questions on there, that would be great. I'm hoping you can all see that on your screens, and then we will go into the Q&A section. I'll give you a couple of minutes just to fill out the little poll. Thank you. And number 3 is really interesting to us. So if we've changed your mind about something with the webinar today, it'd be really interesting to find out what that would mean. Perfect. Thank you so much for the responses that we're getting. I'll leave them up on your screen, and if we can give the presenters a little bit of a break from talking for nearly 1.5 hours, I think. And if we go into, is there any questions? Like I say, you can pop your hand up, and I can give you access, so you can turn your mic on and ask the question. Or if you'd like and have a question, you can type it into the chat on the Q&A. Happy for you to do either, and I can pose them to the presenters. So we've got a comment. We've got Ed. Let me see if I can turn on your allow mic. Yeah, Ed, if you'd like to, I think you've got control of your mic now. So if you.
Thanks, Irene. I just wanted to mention, it wasn't really mentioned in the presentation, although there was a discussion about single people. I just wanted to mention that obviously masturbation is part of sex and relationships, so although it wasn't explicitly mentioned and it's covered by a lot of the things that we discussed, it's something worth bearing in mind, especially when we're talking to single people, that even single people without a relationship and maybe without much hope of a relationship, essentially, there may still be a discussion to be had with them about that.
Thanks, Ed. Yeah, I appreciate that. It's something that I definitely speak about quite a lot. When I speak to people, I think it's something that's really important that we touch on. So yeah, thanks for bringing that up. And I think that it's something that we're probably even less happy to talk about than sex within a relationship. So you know, even just what about when you're on your own might be a way of talking about that doesn't, you know. So I think that but you bring up a very important aspect that perhaps if people have an appetite for, we might be able to bring up in our more advanced training.
Thank you.
But thanks for nodding to that.
Jill, I've given you access to your mic if you want to. Yeah.
Thank you. Yes, I've posted in the comments as well. I think it would be really interesting to have conversation around how voluntary sector groups can be part of this conversation. We're lucky to have Joe locally to us at Speakeasy, based in Bury, but we're often seeing people for long term, and as we've already heard today, that the need or the want to have these conversations can come up at different stages for different people. But I do think that we have particular challenges as well, because most of our activity is group based and people may feel less willing to have conversations with their peers, but it's sort of how we can be part of that conversation. I used to personally work for a bladder and bowel charity as well, so I think I'm perhaps a little bit more comfortable and have knowledge that most speech therapists don't have, but I'd really like to open this conversation up. We're not the only voluntary sector organisation out there supporting conversations.
You're on mute, Fahim.
Thank you. Thanks, Jill. We have one question which just addresses if we don't have a nurse in our team, how do I manage the issues related to medication? I think that's placed for you, Joe.
Yeah, and I think Tamsin probably got quite a bit to say about that too, to be honest. I think, but in fact, actually, I don't know, Tamsin, do you want to go first?
Yeah, I mean, I think again, it's probably about signposting, isn't it? Then it's about just giving that limited information that medications can impact. So whether that's medications that they're on that are affecting sexual function, and again, it's not asking you to go beyond what you would normally do within practice, but again, hopefully the presentation has highlighted some which might be having an impact. So you might encourage them to go to speak with their stroke clinician or their GP, or depending on what context you're seeing them in, to have a discussion. So it's more about alerting patients that it's possible that medication may be part of the issue. And again, with all of this, unpicking exactly what the cause is, we've highlighted there are so many contributing factors here, haven't we? So it is going to be a bit of trying things out. It might be that, you know, if it's an option to make some changes to medication, that just that fact that they're talking about it, that that's something that potentially is within their control to be able to go and address, that in itself might actually start to help some of the other aspects of, you know, this is something that I can do something about, whereas previously feeling really quite out of control. So yeah, I think just again being able to have the conversation, even if you haven't got the answers about whether they, you know, the medication is or is not the culprit, it's just yeah, being able to say, well, it might be. Might it be worth having a chat with your GP about it?
Yeah, I think that's right. And pharmacists as well can be helpful in these situations too. So, you know, cast your net wide, I think. But that whole thing of not knowing and going away and finding out is completely acceptable, I think. Probably a lot of nurses in your teams won't know the answer either without doing that. So, yeah.
Thank you. We've got an interesting comment in the chat, and it addresses sort of experiences as assault around consent and communication as a major topic for people with acquired neurological conditions. Do you have any advice in how to approach this, since capacity to consent for sex intimacy is time situation specific for people or persons, partners?
Yeah, I think this is a big thorny issue, and I think probably definitely a subject for our next training. Yeah, I mean, obviously there's a legal aspect, isn't there, around capacity to consent to sex, but actually it's really to meet that standard actually doesn't necessarily mean that that it's without concern for all parties involved. So I think, yeah, it's out with probably our discussions for today, but is definitely an area that we will be picking up on in our next training.
Thank you. Chloe Wilkins also asks, how should you suggest managing sex if a person has speech difficulties with regards to consent? So similar kind of question. So I think Tamsin said we'll address that in the advanced section of the training. We will go into more depth into, we're hoping to look at how conversations can be had and how to increase sort of them conversations within the advanced section, because that will be a face-to-face event hopefully next February, and your responses today, we will take them into account when planning that as well. I'm just going to go back and check the chat just to make sure there's no other questions in there. Just bear with me a second. Yeah, so no other questions. So just thank you so much for everyone joining us today, and thank you for your time, and thank you for Joe, Tamsin, and Leona's time, and Abby's as well. You know, in coming together and helping us formalize this training. So thank you very much.